So as far as disclosures, like Dr. Bradley, I also chair a committee in a cooperative group, which is now the Alliance, was the old CLGB, North Central Group and the Surgical Group. And while we don't have protons currently, we do have an initial agreement to bring protons to Syracuse, looking at a few years down the line. All right, learning objectives. So as background, when we look at locally advanced non-small cell lung cancer, with primary radiotherapy, despite our best efforts, if you carefully look, local tumor control is about 15%. This is in a series where they went and did bronchoscopy on everybody after radiotherapy. And with modern chemoradiotherapy, infield failure based on CT imaging is probably at least 1/3, and if you were truly to do PET imaging and biopsy these folks, it probably would be quite a bit higher. So local recurrence remains an issue for patients with locally advanced non-small cell lung cancer. And the hypothesis, which we have not come close to proving, is that modulating the way we give radiotherapy, particularly concurrent with chemotherapy, will improve outcomes. So in the new millennium, you know, it's a different world, and as Dr. Langer said, I've been at Syracuse since 1993. It's a different world in the new millennium. We now have things, a lot of acronyms, intensity-modulated radiotherapy, so we can focus the dose exactly where we want it and protect the surrounding areas much better than we used to. Image-guided radiotherapy, we can actually see where the tumor is every day on a CAT scan, line it up, so we know that we're hitting the right spot inside the body. We just don't rely on skin markings. And 4D planning, so we can see how much tumors are moving, and we actually have many different techniques to account for tumor motion. So you would think all of this would shift the therapeutic index, but there's really been no change in the standard radiotherapy schedule going back to the 1970s despite these advances. If we look at dose escalation, a lot of enthusiasm for dose escalation with the development of 3D techniques. So the dose of 74 gray in 2 gray fractions was studied by several groups, North Carolina, the CLGB, the North Central Group, and the Rtog. All of these studies showed improved survival compared with what we consider the standard of 63 gray in Rtog 9410. So encouraging outcomes of 24 up to 37 months. And we just heard about the phase 3 Rtog study, Intergroup trial led by Dr. Bradley, 0617. And this was really a 2x2 design, looking at escalating the dose to 74 gray as well as adding cetuximab. And not only was this a null trial for the addition of higher doses of radiotherapy, this was a roundly negative trial. So patients that received higher doses of radiotherapy, on the whole, survival was significantly worse, 19.5 months with 74 gray versus 28.7 months with 60 gray. More severe esophagitis or toxicity, which we might have expected, but interestingly, local relapse was also increased in the high-dose arm, and maybe Jeff Bradley has a good explanation for this, but I don't. So this was a very well-conducted trial, allowing state-of-the-art technology, good quality assurance, and this is where we are, at 2013. So, this is the way perhaps I look at things, is that perhaps giving small doses of radiotherapy against the big tumor, maybe the more you spit at it, the more it kicks back. So what about alternative approaches? Well, one of the things that's been studied quite a bit in the past is hyperfractionated radiotherapy. Hyperfractionated means giving more fractions, usually a lower dose each treatment. The Rtog looked at giving 1.2 gray twice daily up to almost 70 gray. That was one arm of the 9410 trial concurrent with chemotherapy. The theory is the lower dose per fraction, the less late toxicity. Unfortunately, we did not see improved outcomes despite increasing to almost 70 gray. In addition, the late toxicity was somewhat increased on the BID arm, not reduced. So it doesn't look like hyperfractionation is the way to go. On the contrary, we now have the ability to, what we believe, safely study giving higher doses of radiotherapy every day, or hypofractionation. Hypofractionation, the larger dose you give, the more concern about increased late side effects, but if you can conform your dose, then you should be able to limit late toxicity. There's several phase 2 studies from the Europeans, the UK, and the Korean group, suggesting that giving doses of 2.4 to 2.75 gray are feasible with concurrent chemotherapy, with somewhat provocative outcomes in the time that these studies were done, although there still remains some concern about the potential for late toxicity. Active trials in the CLGB, which is now the Alliance, and Rtog, which is now the NRG. CLGB is looking at hypofractionation in a phase 1 trial by reducing the number of fractions, maintaining the dose at 60 gray, and increasing the dose per fraction. We'll shortly open an arm where we go in 3 gray fractions for 20 treatments. And the Rtog is really going ahead with a more novel approach, looking at individualized adaptive radiotherapy using FDG PET scanning during treatment, and they will be giving higher doses per fraction, as high as 85 gray in 30 fractions. Well, outside of fractionation, what else? Is there any advantage to changing the particle that we use? And this is from the New Yorker and may summarize things on proton therapy overall. Right, so proton therapy, we're talking about using charged particles. The physical properties do differ from photons. There's potential for better protection of normal structures, but the treatment planning is really relatively immature compared with photons. You know, we've been planning and treating with photon therapy for decades, and the experience we have with protons is really pretty much brand new outside of a few centers in the world. The treatment planning is relatively immature compared with photon therapy. There's a typical technique called passive scattering, which may be analogous to three-dimensional radiotherapy, where you always have the entire tumor in one field. And this has been used in the majority of published studies. There are newer techniques that have been developed, and IMPT means intensity-modulated proton therapy. This is more analogous to IMRT, where you can kind of paint the dose and look at different parts of the tumor and really get the dose to where you want it to go, although there are some concerns doing this in the lung in patients that are treated with protons. It's believed that the biologic efficacy is similar between protons and photons, although there's some preclinical data suggesting there may be a slight advantage for proton therapy. Carbon therapy, which I'm not going to talk about today, is also a charged particle, is much more expensive even than proton therapy, but biologically may have a higher kill effect than typical radiotherapy. So if we look at why proton therapy may be helpful, it's really attributed to something called the Bragg peak. So in typical photon therapy, basically the beam comes into tissue, builds up very quickly, and then passes through tissue, slowly getting absorbed less and less and less. With protons, there's a low dose at the entrance, it builds up rapidly, and then nothing passes through. Everything is given off, hopefully around the tumor, and then you drop off to where nothing passes through. So there's really no exit dose at all. And where this is probably most advantageous is in the treatment of pediatric cancer, particularly CNS disease. So this is a brain tumor treated with typical photon therapy. You can get a high dose around the tumor, but you're going to scatter the low dose, which you see here in green all around, whereas with proton therapy, nothing comes through. So you're really limited to exactly where the tumor is, and at least the ipsilateral brain. Even more remarkable is when we're talking about craniospinal radiotherapy with X-ray photon therapy. some dose is going to come through. With proton therapy, you can model it so really everything stops right at the end of the spine and there's no pass-through. So potential huge impact on growth for pediatrics and also marked reduction, at least in the potential for secondary malignancies. These are the currently operating or close to operating centers in the country. I think there's 12 operational on the way to about 24 within the next few years. And the cost of proton therapy varies, but a low of about 25 million, and some projects, New York City, San Diego, et cetera, eclipse $200 million. A lot of controversy in the Wall Street Journal. This is based on a SEER study that suggests, and I'll just go to the next one as well. There's a SEER study that was published last year for prostate therapy, which suggested that IMRT was better than 3D in reducing GI side effects, but that IMRT was also better than proton therapy in reducing GI side effects. So some insurers, particularly in California, stopped reimbursing for the treatment of prostate cancer. And of all the patients that have been treated with proton therapy, about 85% have received prostate cancer, have received therapy for prostate cancer. That being said, there have not really been reports of undue toxicity. It's just when you look at large databases like the SEER database. This is an example of prostate cancer, proton therapy, one beam from the one side, one from the other side, so you don't get any scattered dose otherwise around the pelvis. For IMRT, you still get, in the red is the high dose, you still get the same distribution around the prostate, but the dose is spread out much more. For adults or older patients, the downside of having low dose spread out is not very clear, although theoretically there'd be a higher risk of secondary malignancies. It's not true that would be the case in a population where the age may be a median of 70 or higher in some situations. Move on and talk finally about lung cancer. So this is early stage lung cancer, and Jeff Bradley did a great job talking about SBRT, but this shows a typical dose distribution with photon therapy, so regular X-rays. So we have the technology and the experience now to give incredibly good treatment with photon therapy. We also have something called image guidance. So with image guidance, we have the ability to use the CAT scan that we did the planning on, take another CAT scan every single treatment, make sure the tumor lines up appropriately, and if not, we can shift the patient so the tumor is right on target. Most centers with proton therapy don't have this technology quite available at this time. So again, we've excelled at moving ahead with planning and delivery for photon therapy. We're just building up for proton therapy. This is a study from Massachusetts General Hospital showing them when you use typical proton planning, which is just a few beams, you may actually drag the high dose of radiation to a larger area. So in this case, we're getting more radiation into the soft tissue and ribs, and there was a question about rib fracture before. The reason for this is something called range uncertainty. Right? When you're moved from soft tissue to a much less dense tissue like lung, there's much less information on how far we know that the proton is going to travel. In order to account for that, you have to give some additional margin on your tumor, which could mean getting additional dose to the surrounding critical normal structures, in this case, the chest wall. With newer proton techniques, and this is IMPT, this is a study from Vienna showing that you get a very nice high-dose region. It's not dragged down into the chest wall. In addition, there's definitely reduced low-dose lung, heart, and esophageal radiotherapy with proton SBRT. That being said, Jeff Bradley showed this data before. There's phase 2 data of 97% 7% in-field local control. It's hard to imagine that we can improve upon that with proton therapy. The question would be, is there some undue toxicity that we're not aware of that may be better with proton therapy? There is a fair amount of small studies using protons for early stage disease. Loma Linda, California is the largest, showing pretty good results. If you go to high dose, 50% 4-year survival, pretty impressive. Local control, very good for peripheral lesions with high dose, similar to Rtog, similar to the Rtog trial, and very little pneumonitis. And there was a so-called meta-analysis, which wasn't very many patients, but it suggested similar outcomes with SBRT, proton therapy, and carbon therapy. If we move on to locally advanced lung cancer, there's actually much less data. So this is what I would say probably state-of-the-art proton therapy with intensity-modulated radiotherapy, where we sculpt a high dose of radiotherapy to avoid the spinal cord, kind of cut through the esophagus, but we don't miss the tumor at all. So this looks pretty good. The thing that you don't see initially is all this is a low-dose radiation, which is really splayed out. And when we look at dosing for lung cancer, one thing we take into account is the V20, and that is the amount of lung that gets exposed to a fairly low dose, 2,000 sonogray, 20 gray, or even 5 gray. So this will be increased with IMRT compared to standard therapy. And this is a state-of-the-art proton plan, which shows really no dose going through into the lung elsewhere. So the V20 is markedly reduced, as well as low-dose radiotherapy to the lung by the use of proton therapy. This is a study from MD Anderson, really going over the same thing, but in the same patient. So it shows here's protons, here's photons. There's much less radiation that's being exposed to the contralateral lung, also less to the heart and the esophagus. So one of the questions that remains to be answered is what we see on paper, the dosimetry, does it translate into real life? And there are some concerns of complicating factors. The depth of penetration of the Bragg peak can vary significantly based on tissue density, as I talked about before, and particular concerns in lung. Range uncertainty, where you need to add extra margin to tissue. So in locally advanced lung cancer, there's potential to have slight miss of tumor and slight overdose of the esophagus or neighboring organs. And accounting for tumor motion becomes very complicated but critical with both traditional proton planning and the newer techniques where if you're not precise enough, then you're going to either miss or overdose. So there is a good phase 2 trial from MD Anderson. To my knowledge, it's the only phase 2 study that's been published for concurrent chemoradiotherapy. And these are all PET stage patients. They used the older planning, the passively scattered protons, and they did not have the availability of cone beam CT to look at the position of the tumor every day. Median survival was very promising at almost 30 months, and low local relapse and acceptable toxicity. There's some other data in literature. Florida has a published series, but only 19 patients. Basically shows that you can get away with proton therapy with limited toxicity, and they only had 1 in-field progression, but short follow-up. There also are trials for primary radiotherapy, but these are generally selected patients in large series. Generally, they do poor with proton therapy alone, as you would expect locally advanced patients to do poor with any local therapy alone. Reirradiation we talked about, series from MD Anderson suggesting reasonable 1-year local control with acceptable toxicity, but certainly some risk of increased toxicity with reirradiation. And there's a few studies looking at the ability to give postoperative radiotherapy with reduced toxicity when you use proton therapy. There is a newly opened phase 3 trial which will hopefully answer the question of whether or not there's an advantage for protons. This will be 60 to 70 gray protons versus photons, and the plan will be based on the volume constraints of the organs at risk. There's several other ongoing and planned institutional trials as well, looking at pre-op hypofractionated therapy, and IMPT is intensity-modulated therapy with simultaneous integrated boost. That means you can paint part of the tumor to get a higher dose while protecting the surrounding area. So in summary, I think one of the issues for us now is RTOG 0617 set the bar pretty high, 28-month median survival, in the context of modern staging and modern therapy. Whether altering the way we give radiotherapy will have any impact remains unclear. Protons have the potential to permit less toxic therapy, but there's very limited data. Techniques are evolving, and perhaps proton therapy may facilitate getting to the right RT schedule. Thank you very much.